I was first exposed to drugs and alcohol when I was 13. I started taking prescription pills, and from there it was, drinking and pills and marijuana. I got into meth and crack, and my life just fell apart, and I became homeless, and I had a loved one shot in front of me, and I looked at myself in the mirror one day, and I was terrified, and I didn't recognize who I was. The things that have helped me cope without drugs and alcohol, I've really changed the people that I spend time with. We go hiking and we go to the beach and we find these like really exciting ways to have fun. If I could say one thing to someone that is using now, you're not alone. There's always a way to step off this path. You're not a bad person because you've done this. You can make a different choice, and there's really like nothing more rewarding than that. Thanks for having me here to speak to you guys about my experience. It's a little, it's crazy to see the video. Um, it was such an opportunity for me, but so normally how I tell this story, I will start by saying, "Hi, my name is Hannah, and I'm an addict." In my recovery community, that's how we identify. It's how we identify with each other. I also work in treatment, so I understand that my addiction doesn't define me. And then I struggled with substance use disorder and mental health issues for the majority of my life. So to give you a little bit of background, I was actually born in California, but I grew up in Utah. I had like a very standard middle class upbringing. My parents were lovely people. They're still married today. I was just kind of the black sheep in my, very normal family. Um, I started recognizing that I was struggling with mental health issues around age 11, probably. And by age 12, I was cutting, I was contemplating suicide. I was miserable. I and God bless my parents. We did not believe in mental health, like it was a myth or something. There wasn't a solution to how I felt. It was just, you'll be okay, be happier. Um, and so, when I share this with my community, I tend to say drugs saved my life. Um, when I found prescription pills at 13, I probably would have killed myself if I hadn't. And so I uh, became my own pharmacist, and decided that, you know, that this is what I needed. I started using opiates and stimulants together because that resulted in my preferred effect. Um, and I genuinely, for a period of time, believed that this was how everybody, survived life. That this was how people, coped and dealt with life. Um, and I mean, all through high school, I was, a very normal teenager. I was on the cheerleading squad. Uh, I was on the debate team. I did extracurricular activities. I graduated with honors, but I suffered from substance use disorder that entire time. Um, when I went to college, uh, it was, well, so when I was 16, I shot up heroin for the first time. And I was like, yes, like this is everything that I'd hoped it would be. But I was really afraid of being physically addicted. Like that was, like I was not down with that. I didn't want that. Um, so I stopped using the opiates and stimulants for a while. I went to college, and there was like great expectations of what I needed to accomplish and what I needed to be. And so when I failed, and dropped out 2 years in, that went over like a lead balloon. Um, and to make a really, really long story short, I experienced a um, personal traumatic loss. Um, and I was filled again with that like deep, dark, endless sadness that I'd felt when I was a child. And it's like I remember my solution. Uh, and my solution when I was younger, I managed, and I felt like it was, manageable again. So I'm 19, doing heroin and meth consistently. Um, and I had, I had a house, I had a car, I had friends, I had family, I had a couple jobs, and then I didn't. And it was this just very quick decline. I very quickly became homeless. I felt helpless and hopeless and depressed. Um, I mean, and uh, being homeless was on its own traumatic experience. Um, I attempted suicide in 2014, and it was the first time that I, went into a detox, and started trying to really address the substance use disorder that I was experiencing. And I was in a like hospital, um, like stabilization and detox unit, and I just remember I was standing outside the nurses' station, like just down the hall, and I don't know who the nurses were talking about, but one of the nurses said, um, she said, "Oh God, she looks like she's really suffering," and the other nurse said, "Well, what did she expect? She's an addict," and that like indifference and disgust like really stuck with me. The first time that I was sexually assaulted on the street, I didn't go to the police. I was arrested frequently for, this crime or that crime, and police, treated me like I was human waste. And in the back of my mind, I had this, what did she expect? She's an addict. Um, and so I I'm now like experiencing this solution as, like the problem in my life. And I'm like in and out of treatment, trying to find a way to really, address myself as a whole. And I was continuously in treatment centers where, um, it was like there was just that sense of like indifference, and sort of like, well, you know, people like you don't make it. And so when I moved to California, it was truly life or death for me. I was probably 80 pounds. Um, I had a bunch of my teeth knocked out. Not that they were, any, like I wasn't saving them, smoking meth and shooting meth. So either way, I had been, you know, beaten, sexually assaulted. I'd been robbed. I just been through the ringer. And I had one suitcase with me, and it had two massive winter coats, a pair of shorts, a pair of leggings, and a couple of t-shirts, and a pair of Sorel boots. And that was what I had. And when I went into detox, I detoxed so hard. It was very difficult. And a lot of my, mental health issues were heightened by the fact that I was, detoxing off a lot of heroin and meth. Um, I substance use disorder programs didn't want me because of my mental health issues, and mental health treatment centers didn't want me because of my substance use disorder. So I was really stuck. I bounced around to a couple of treatment centers until I finally landed in one in Pasadena, that was like as dual diagnosis as it comes. Um, I, I did this program. I got into PHP, and like they, during my residential stay, like they really helped me to understand, you know, like the substance use disorder, but also that like my mental health went hand in hand with that. And so I started really addressing them both, um, as a whole. So I was still me. I self sabotaged at 90 days. I'm in a PHP program, and I went into this PHP like, arms in the air, like, yeah, like I relapse, and f this is whatever. And um and the group facilitator looked at me and he said, "Wow, okay, thanks for being honest with the group. What's the next step to get you back on track?" And I'm like, "What?" Like, I'm pushing away. And I finally had someone that like held me and was like, "No, you can still make it." And gave me hope that like I wasn't this, hopeless, helpless cause. I stayed in that program for another month, and before moving to San Diego, where I lived in a sober living, I started working like so hard on my mental health. I was doing, EMDR and trauma treatments 2 or 3 times a week. I was seeing a psychiatrist. I was seeing an individual therapist. I was going to outside AA and NA meetings. Um, and it was like for the first time, uh, I felt like I was being treated as a whole person. Like, um, it's like not just my substance use disorder was being treated, but my mental health was being treated, and my life started to fall into place and felt, more like it was a manageable experience. I today, um, I I mean, I worked at the same treatment center for 3 years. I work in a mental health primary treatment center, and I've gotten to kind of like work my way up into, um, like a better position. These people know me, they know my history, and they accept me, and they allow me to be me and utilize my tools, to be a productive member of society. Um, I'm a person in my community that people go to if they're struggling. My family wants to be around me. My dad spent his last birthday in San Diego because we're not like traveling with our newborn right now. I have a 4-month-old daughter. I had a healthy pregnancy. I'm engaged to the love of my life, who I really got to like grow up in my sobriety with. Um, Neither my child or my fiance have ever seen me high, messed up, um, wasted, whatever. And as long as I have that, you know, that whole treatment where I'm treating me as an entire person, um, they'll never have to. I really appreciate you guys taking the time to hear my story. Thank you so much, Marla, and everybody for inviting me to do this.
So our goals and objectives for this talk. So through this talk, we are going to identify, and by the end of it, hopefully y'all will come away with multiple different learning points. But really our goals are to identify the effects of methamphetamine, which most of us know well, but I always like to start from a very basal level, build up from there. Identify some of the long-term complications of methamphetamine, identify the changes in methamphetamine use frequency, both in the Southwest and across the nation, identify rates of methamphetamine-related complications as illustrated by methamphetamine-related heart failure, which I'm going to be referring to as meth-ref throughout this entire talk. Identify changes in different methamphetamine production methods and trends, identify the complications of the P2P methamphetamine production method. And then finally, we're going to formulate a theory on why methamphetamine is more toxic now. I think that y'all will find that this talk will be asking questions throughout the entire talk that hopefully will be answered throughout it. We're going to be building on different levels to hopefully formulate a hypothesis of why methamphetamine is more toxic today than it was about 20 to 30 years ago. This is really a multifactorial issue and problem, and y'all will see that it's more complicated than just one answer. So a little bit about me and where I come from. So I grew up in Texas. I did undergrad in medical school in San Antonio. I did my surgery intern year at Boston Medical Center, where the patient's primary drug of choice were alcohol and heroin. However, when I was there, fentanyl cases were rising. And that's when really the big rise of fentanyl in New England was happening. I then completed my emergency medicine residency in Tucson, where I saw a very large amount of methamphetamine intoxicated patients. On the right-hand side, we actually have a homeless encampment where I believe this was actually a drug bust of methamphetamine. And then also on the top right, we see that Tucson itself and south of there near the border has a very large pathway similar to San Diego for methamphetamine trafficking. So long story short is that based off of my experience, I have a lot of clinical experience with methamphetamine intoxicated patients. One thing that is interesting actually from a toxicology side is that I almost never get called about methamphetamine intoxicated patients. And the reason why is our physicians at Hillcrest, Mercy, and our other consulting hospitals are so good at dealing with it because they see it so often. I tend to only get called if the patient is terribly sick. So first starting off, what is methamphetamine? So in short, methamphetamine is a sympathomimetic. It causes a release of dopamine, norepinephrine, as well as preventing the reuptake of other biogenic amines, so serotonin, things like that. Basically, it causes an excess of neurotransmitters at the nerve terminal, causing excitation and other problems. What it does is it causes an agonizing relationship at the alpha-1 beta dopamine and norepinephrine receptors. What that means is you are basically having more effects at all of those receptors, and it causes more basically sympathomimetic syndrome, which we'll get into in a second. The interesting thing is that methamphetamine, and you can see methamphetamine on the top right, is metabolized to amphetamine. And because of the extra little methyl group off of the nitrogen, what we have is we have more central nervous system penetration. So it gets into the brain better. So we see more brain effects compared to just using amphetamine. When meth is metabolized to amphetamine, then we see a lot more of the peripheral effects. One other thing that we'll get into later is that methamphetamine exists as two different isomers. Basically, imagine a molecule as having a left-hand version and a right-hand version. And what happens is the body understands those two molecules differently. Okay. And the big thing about meth, and we'll get into this extensively later, is that the D formulation of meth is more CNS active compared to the L form of meth. Otherwise, and I imagine y'all will know this very well, that methamphetamine intoxication can look very, very different based off of if someone injects it, smokes it, snorts it, or how they're doing it changes. Also, the chronicity of how often they do it, how frequently they do it, as well as what the person's tolerance is. A person who is methamphetamine naive may react to a much smaller dose in a much more severe way than someone who is um, a chronic user and has a tolerance. And I imagine that all of you all know this as well. And the other thing about methamphetamine, just as a whole, it exacerbates prior psychiatric illnesses that the person already has. Talking a little about sympathomimetic toxidrome, and I'm a toxicologist. I know my toxidromes very well, but a toxidrome is basically a constellation of symptoms due to a illness or some other type of toxic presentation. So what methamphetamine does is it causes a sympathomimetic toxidrome, basically by hitting all of the norepi and other receptors that we were talking about before. So what we see is we see agitation, we see a high heart rate, we have high blood pressure, we have fast breathing, we have sweating. We also have hyperthermia, and that occurs for two reasons, or basically because a person is so active. They're sweating, but they're also so active that they're causing increased heat production. All of that being said, this is what we deal with, and we all know this very well when we have a sympathomimetic person. The problem is a lot of those problems can lead, or a lot of those effects can lead to long-term problems. All the cardiac effects can lead to a cardiomyopathy or heart failure, which we'll get into later. The heart effects can also lead to pulmonary hypertension. Basically, the lungs have more pressure on them. We can have a cognitive impairment that is not related to psychiatric illness and a cognitive slowing. We can also see new psychiatric illnesses. We can see an exacerbation of prior psychiatric illnesses. Also, we have higher rates of malnutrition because people are either not eating or they're awake all the time. Methamphetamine also suppresses appetite, and other stimulants suppress appetite. We have a premature aging, which we can actually see of our methamphetamine user on our top right side. The other thing is that we see dental issues, and this happens because of many reasons, both neglect, the mouth is dry, which is another effect of methamphetamine, as well as bruxism, which is the grinding of the teeth. And nationally, this is going to be something that y'all know as well. From 2019 to 2020, the New York DEA noted a 200% increase in methamphetamine. And the reason why I'm bringing this up is other parts of the country are seeing increasing rates of methamphetamine. They're also seeing increasing rates of fentanyl seizure, which will be something we talk about later. There's been a dramatic increase of methamphetamine use within the past two decades, as well as a 10-fold increase of deaths from psychostimulants from poison center data. Talking a little bit about national data. So this is data that was presented of basically calls to a poison center over 2 decades. And this is a national poison center. And what they did was they collected all of the calls, did a retrospective analysis, and saw how many calls per 100,000 people, or the rate of exposure per 100,000 people. On the very bottom of the graph, we have our circle lines. And what that is suggestive of the Northeast. So basically in the New England area, we're seeing not that much of a rise of methamphetamine use. However, in the Midwest and South, we're seeing actually pretty substantial increases. In the South itself, we're seeing almost a 3-fold increase of rate of methamphetamine exposures per 100,000 people. In the Southwest, it's only 2x. So it's only twice as many exposures per 100,000. Over a 2-decade period, that is still a substantial amount though. What we're also seeing is that this is specifically methamphetamine and not just psychostimulants. So what we're seeing, and this is a national population data, is that methamphetamine use is increasing substantially. All cases are increasing. You can see it goes from 0.05 to almost 0.02, and that's national. And that's all-encompassing substances. We're seeing both the increase in single substance and polysubstance meth exposure. So someone who uses meth and alcohol, or meth and THC. And a lot of the patients who use methamphetamine also use multiple different drugs of abuse. And then finally, this is from the DEA 2020 data, and it's looking at what are the rates of psychostimulant deaths in the US. And this is over 1 decade, the data is now 4 years out of date. That being said, from 2007 to 2018, we see a almost 5-6-fold increase of psychostimulant involving deaths. So what you're seeing is that as a whole, from a population scale, we're seeing increased rates of methamphetamine use across the nation. A lot in the South, a lot in the Midwest, but we're also seeing a lot in the Southwest, which I think everyone on the call who has been following methamphetamine will know that as well. But the next question is, what do these increased rates of methamphetamine translate to? What does increased use actually mean? So this is California data. So this is a paper that was published pretty recently, but is a socioeconomic burden of rising methamphetamine associated heart failure hospitalizations in California from 2008 to 2018. And they pulled data from the basically California's Health and Human Services Office and looked at all cases of heart failure in California. And they identified over 1 million heart failure cases within that decade. They identified 990,000 of normal heart failure, non-methamphetamine related heart failure, and they identified 42,000 patients who had heart failure that also use methamphetamine, which we'll call methref in this. They noted that over a decade, the amount of methamphetamine-related methref hospitalizations increased 585%. However, during that same period, we found that normal heart failure decreased by 6%. So there's a discrepancy between those two numbers. What we're also finding is that there is a sharp increase in the amount of healthcare costs. They found that over a 10-year period, normal heart failure costs increased by 82%. And that's just basically normal healthcare inflation. And I will say that is a lot, but it's what we would consider normal healthcare inflation. And we're using as a benchmark. The problem is that we also found, or they also found, that the increase of cost for methamphetamine-related heart failure cases rose by 840%, which is almost a 10-fold difference in healthcare costs to the population. So talking more about methref, these patients are substantially different from our normal heart failure patients. We're finding that a majority of these patients are less than 65 years old, and most of them are 35 to 54 years old. Many of these patients, or many normal heart failure patients, are greater than 65 years old. This is a disease process generally of the elderly population. These patients are almost 80% male and about 50% white. Further, many of these patients also use other substances such as tobacco, alcohol, and other drugs compared to the regular heart failure patients. The other thing is that we see is that they do not have the comorbidities that we normally associate with heart failure, and that includes hypertension, atrial fibrillation, and diabetes. All of those problems tend to come in concert with heart failure, and these patients don't have that. The interesting thing is, and I think this is dovetails with what we were talking about before. Over a 10-year period, they saw the relative frequency of just methamphetamine on patients' charts increased by 3.8-fold. Patients who presented for a UTI and happened to use methamphetamine increased by 3.5, like the relative frequency increased by 3.5. So what we're seeing is that all coming patients present with methamphetamine use more. Also, we're seeing a substantially higher use or substantially higher rate of methref from the 2008 to 2018. And hopefully I'll be able to tackle this, why this happens in a few slides. But basically what we're seeing is increased cardiac complications from methamphetamine use that we did not see previously. Okay. And then the other thing is what are our patients like and what are their payer system like? So we see mainly the vanilla heart failure patients are Medicare, suggestive of that they're older, and MethRef as Medi-Cal suggestive that they may be more younger. And then finally, where is this affecting? So what is the spread? And so on the top left, we have our 2018 graph. Okay. Blue is not as bad. Red is very bad. Okay. As we go from blue to red, it gets worse. And we see more cases of MethRef. So on the far left, early on, we can see some green east of San Francisco. Over time, the entire map changes and there's very few spots of blue. So we're seeing on a statewide level, increasing rates of methamphetamine-associated heart failure. What we're also seeing is that the areas that were previously hard hit are getting hit even harder. The next question is, where is this methamphetamine coming from? And I imagine that everyone on the slide is going to know exactly what this is, but this was from the news, I think earlier in the week or even late last week, of methamphetamine that was being smuggled across our southern border, and it was being smuggled along with onions. So not surprising to anyone, most of our meth is coming from the Southwest, and that's nationally. That the Southwest is one of the main corridors of methamphetamine to the rest of the nation. And this is DEA data from 2020, and we're showing a dramatic increase of the methamphetamine seizures from 2013 to 2019. Next question is, how has production changed over the last decade, 2 decades? So back in the old days, amphetamine used to be legal. Okay. And what we kind of know is that L-amphetamine is legal. So back in the old days, you used to just go buy amphetamine on the streets at your local pharmacy and use for your congestion. We don't have that anymore, I guess, fortunately or unfortunately, whichever way you want to look at it. But the big way to think about it is L is legal. And that's kind of what we'll get into in a second. And one of the things we think about when we think about different stereoisomers. So there's many different types of synthesis. First type of synthesis, and many of y'all will be familiar with, is the red P method, which uses red phosphorus and iodine. And then one of the main reagents is Sudafed. We also have our Nazi method, which is a little bit harder to use because of regulation with liquid ammonia. But it basically uses liquid ammonia, other alkali metal reductions to make methamphetamine. We have our one-pot method, which is also known as the Birch method, and we'll have a few slides on that in a second, and the P2P method, which we'll spend a significant amount of time on, and that's phenyl-2-propanone. So what kind of happened? So back in the old days, and I'm talking prior to 2006, the main production of methamphetamine in the US was with the red P method. And what they used Sudafed, combined it with red phosphorus and iodine to reduce Sudafed into methamphetamine. And on the bottom left, you can actually see Sudafed, and we have that hydroxyl group, that OH. And what we do is we basically pop off that group and we cause a production of D-methamphetamine. We do not, when we use the red P method, we do not produce any L-methamphetamine. And as we were talking before, the D-methamphetamine is the one that is more psychoactive compared to the L-methamphetamine. So it produced a more pure, I guess, not psychiatric, pleasuring experience for these people. This was the main production method before 2006. The problem was that in 2006, Sudafed was then more regulated and stuck behind the counter, and people could only buy so much, which then caused production to change in other methods. Talking a little bit about how to produce, we can see that the red P method is decently involved. However, me being a like biochemist in undergrad, this is a very easy production method. I'll say that. I did production like this or I did synthesis like this in undergrad all the time. The Nazi method is a little bit more volatile, and that's because of the liquid ammonia, which can explode and then is also very caustic. And then we have more of the liquid ammonia and then other types of, you see that's a leak down at the bottom. And then the one pot method, and I'll have to, for these last few slides, I'm going to credit Dr. Kirk Kleinschmidt out of UT Southwestern in Dallas, who I took a lot of either his slides or this method from the slides. So I have to at least give him the thanks and kudos, and I did not do this myself. Okay, but basically for the one pot method, it's difficult. You can't produce it as much, and it's labor intensive. Also, you have to vent off the gas. So finally, the new popular method is we have our P2P method, which we were talking about before, is phenyl 2-propanone. And this was originally invented by the Hells Angels biker gang, and it's also referred to as the biker method. It started to gain popularity really after 2006 because the red P method was much harder to do because we could not, or people could not buy Sudafed as easy. The problem is that most of these reagents are legal, they're cheap. The problem is that they're toxic. So in this production method, they use cyanide, lye, mercury, sulfuric acid, hydrochloric acid, nitrostyrene, acetone, and those are really bad. From a toxicologic perspective, a lot of those could kill you. They are all terrible. I would never let anyone go near those. Other problem is that it's complicated, volatile, and it smells really bad. So it's harder for people to do in small labs, and you would have to more likely centralize it. The other problem with this is that it produces a racemic methamphetamine. What that basically means is it produces both the D and the L stereoisomers. The D is more psychoactive and the L has more peripheral effects. Unlike the red P method, which only produces D-methamphetamine, which has less peripheral effects and it has more central nervous system effects. However, there are some purification methods in other ways that are increasing the amounts of D-methamphetamine compared to the L-methamphetamine. And really, the point of this slide is to illustrate that the standard synthesis with red P is much easier and less labor intensive compared to the P2P method, which you have to use high heat, you have to use other reagents, and you also have to use aluminum. That is much more difficult to make. One other problem is that the number of different synthetic pathways to make methamphetamine by the P2P method are enormous. Okay. This is 6 different pathways that all produce the same molecule, meaning that I cannot tell you what the contaminants in one P2P method are going to be versus another because I don't know what synthetic pathway they use because all of these use different ingredients. So for example, on the 4th one, we have aluminum and mercury. On number 1, we have other different metals. So you can also see, then we have on number 6, we have hydrochloric acid. We are having platinum as our metal reagent on another one. But what we're seeing is multiple different metals being used and multiple different acids and multiple different other reagents. So that being said, over the past 2 decades, we can see that the production methods have changed. So blue is suggested on this slide. Blue is red phosphorus. The red is P2P. The green is mixed birch, which we were talking about is the Nazi method. Sorry, birch is one pot method. But what we're seeing is that the red P method after, 2009, decreases substantially. And then we're seeing an increasing proliferation of the P2P method, so much so that there's almost nothing left that is not P2P. The only line in 2015 that is large is unknown of what they're producing. The other thing is that we're seeing within the past several years is that methamphetamine is getting more pure and cheap. When I was reading this report from the DEA, the problem with this was I couldn't figure out what purity meant. I think purity means it's not being cut with inert ingredients and adulterants, that instead it's just meth, okay? And it's not being cut with starch or sugar or other things. The problem is purity doesn't necessarily mean that there's not other contaminants or fentanyl or other problems with time. It just means there's more active ingredient in it and less cutting agents. We're also seeing that methamphetamine costs are decreasing substantially over the past decade or two. I imagine that y'all will probably be able to correct me that meth is probably even cheaper in San Diego than this. So talking about D versus L, which we talked on before. So D-methamphetamine has been studied and has been rated by users as more potent both physiologic and behavioral effects for patients, that they tend to like it more. So basically the D crosses the blood-brain barrier and then causes more release of dopamine and other happy chemicals so that people have the psychological pleasure from the methamphetamine. And it's also a more potent dopamine releaser, which we talked about before, compared to L-methamphetamine. The interesting thing is that methamphetamine, there are people who use methamphetamine are able to tell the difference between D, combined racemic D versus L, or just L-methamphetamine. And they rate that parts I'm losing my words, that if they were to use L-methamphetamine, they have lower ratings of likability, intoxication compared to if they just use D. So if you have any sort of L in it, they do not like it as much. Also, patients who used D-methamphetamine rated greater stimulant effects and higher abuse likability compared to L-methamphetamine. The interesting thing is at very high doses of L-methamphetamine, you have similar effects compared to D-amphetamine. However, the psychological effects, psychodynamic effects are less than if you were just to do straight D-methamphetamine. So what are the complications? And I'll be very honest when I say that I could not find any scholarly articles talking about the direct effects of P2P methamphetamine production methods and meth compared to other methods. There's no data that I could find. Most of this was based off of anecdotes and other writings that I found. But what I did find is that P2P methamphetamine causes a more pronounced deterioration of mental health. So it causes more pronounced hallucinations, paranoia, schizophrenia compared to other meth production methods. Also, that some patients never return to baseline. That some of these patients may have hallucinations, delusions within hours of starting to use. Whereas in older methods, especially with the ephedrine-based and Sudafed-based meth, that this was more of a long-term problem and only seen after being on it chronically, that we see a quicker and more sudden deterioration in mental health compared to previously. The problem is we're not sure why. We're not sure what the etiology of this deterioration is. It could be that there are toxic chemicals used in production that are still in the final sample. It could be that more people are using higher amounts of methamphetamine because they're trying to get the same psychological effects that they got with previous Sudafed versions. So if we have a lot more D and then we go to less D, we have to use more of the methamphetamine to get us up to the same user likability of the high. The other thing is that it's possible that due to accessibility, more people are using it and people are using it more regularly. So talking about our prior slide, we're seeing that meth is bountiful and meth is cheap. We're seeing that we're having increased use patterns as described by the right side, that there's more methamphetamine on patients' charts compared to a decade ago. And then also that we're seeing more of the complications from the amphetamine, basically since 2006, when we transitioned from a less P2P method to a more P2P method. The other thing is that we're maybe seeing, and one of the reasons why we're seeing increased frequency is because of the cultural war on opioids and the crackdown on opioids, is that patients may be turning from opioids into other products such as methamphetamine. Something to consider, that we may be trading one drug of abuse and societal problem for a different societal problem of drug abuse. And then you're also probably thinking, I've presented all of this information so far, but we also see other things in meth. What about all of the other things that are in methamphetamine, and how does that contribute to this picture? So we, in toxicology, we talk a lot about adulterants, and y'all see this a lot. So discussing what adulterants are. So first we have diluents. And diluents are inert ingredients that can be used to stretch the supply. So we'll use sugar, starch, carbohydrates, basically they're bulking agents to cause the seller's supply to go for longer. Then we also have adulterants, and these are pharmacologically active, and they produce either synergistic or antagonistic effects for the user. What the point of it is either to enhance expected effects or to minimize drug effects. For example, in cocaine, we could add meth to cocaine, or we could add caffeine to cocaine. We're increasing what we think would be the high, or the patient would think would be the high. Or we could mimic, so that's mimicking the drug effects. The other one is enhancing drug effects. So let's say we add a little bit of fentanyl to our methamphetamine. And the reason why we do that is not only to cause a little bit of release at the serotonin receptor to cause a greater euphoria, but we're also using it to maybe counteract some of the negative physiological effects. So tachycardia, hypertension, jitteriness. And we're giving it they're using it to help decrease that, so that they are kind of mellowing out a little bit and not being full sympathomimetic. That's one theory. But really, adulterants are pharmacologically active. The other problem is these can still be very bad. Next, talking about what else are adulterants, and this is where I think more of the talk will be, is contaminants. So contaminants are byproducts or agents used in the manufacturing that make it into the final product. So for P2P, we use cyanide, or they can use cyanide, lye, platinum, sulfuric acid, mercury, aluminum, all of these things that are very toxic. Okay. And it may be in the final product. I was unable to find any actual data to see how many contaminants make it into the final sample, and I could not find any peer-reviewed data on that. That being said, I can imagine that this is one of the reasons why methamphetamine is more toxic today compared to before, because of the reagents that are used that reach the final product that are more toxic. And then also, the other thing is that we are unable, because of all the different synthetic pathways, we are unable to predict which agents may be in the final product and unable to predict what the effects long-term may be. Finally, sometimes people add other contaminants for weird, strange reasons, like crackle wasping, which I've only found a few reports of online, but basically adding bug spray into the methamphetamine sample because maybe it increases the high. I'm very confused. But the interesting thing is that these bug sprays contain pyrethroids, which are a neurotoxin. Generally, in humans, it's actually not that bad. Sometimes your pyrethroids can also be in like tick spray or other things, but generally these aren't, or sorry, dog tick spray or other things, but generally these aren't very toxic. if you were to smoke them and inhale them, they might be. And then our final favorite adulterant is fentanyl. So this is an opioid, which you all know very well. It's an analgesic. It also causes respiratory depression. What we're seeing is and this is all anecdote. I wasn't able to find this, but I know we see, at least from my own clinical experience, I have seen increasing rates of people who have had accidental opioid overdoses because they did not know they were using fentanyl and did not intend to be using fentanyl. Sometimes the goal is to offset the negative perceived effects of the stimulants. Other times, it may not actually be in there. Okay, but basically what we're seeing is increasing rates of fentanyl adulteration, both probably intentional, unintentional. And then the best way to think about it is really you may be killing yourself in two different ways. So not only are you causing all these psychostimulant effects, which will still be ongoing, but you're also causing respiratory depression. And there may reach a certain point where the respiratory depression is outweighed and the person stops breathing compared to just the sympathetic drive and tachypnea, fast breathing that comes with methamphetamine. And then finally, talking about meth versus opioids, that there may be a shift in the user's drug of choice from opioids to meth within the past number of years because of societal pressures. The other hard thing, and I believe y'all probably see this, is that there is no good treatment for methamphetamine use disorder. So for opioids, we have methadone, we have Suboxone, we have naltrexone, we have lots of different modes for medication assisted therapy. Unlike methamphetamine, there have been many studies that have been done that basically have shown that these medications don't work well. And there's a lot of active ongoing research looking at different medications that can help treat methamphetamine use disorder, but none of the data is actually very good. And we're seeing from the few studies I've read, it's like a 30% success rate, which is not that great. And then finally, meth compared to opioids. Meth itself is much, much harder to overdose on. We see it, but it's harder to do compared to opioids, where there's a narrower line of overdose, a narrower edge to walk compared. And then finally, what we're also been seeing that there's been a change in delivery. So methamphetamine is also now being either counterfeited into other tablets like MDMA, and people are accidentally getting it when they don't intend to, or that they're maybe meth is also being formulated in pills and other things. So to summarize, and hopefully I've at least, a lot of this talk is me causing y'all to think about the ideas and what is going on and how this goes. But the kind of the summary of why is meth more toxic now. So what we're seeing is we're seeing increased rates of meth production and traffic of methamphetamine from Mexico across the border and across the entire US. We're also seeing increased rates of methamphetamine use at a population level. So more patients are exposed to meth and using meth. What that also means is we have a greater sample size for negative health outcomes compared to before. The problem is that we're seeing a greater rate of complications now compared to before, not even accounting for the increased meth use over time. And that was illustrated by our increasing rates of meth ref. So we're seeing more use, but we're also seeing more complications compared to before with that use. The other problem is that most of the meth in the US is P2P synthesized meth, which likely has contaminants, also has greater rates of psychiatric illness, also has greater rates of heart disease and other complications. My personal theory of the reason why we're seeing more of the peripheral negative health outcomes and cardiac sequela from the P2P synthesis is because it's a racemic meth and has more peripheral effects compared to our Sudafed meth. And then finally, we're also seeing adulteration with fentanyl and other substances, which can be toxic. So in summary, I believe that methamphetamine is more toxic now because of a multifactorial reason. And all of this is coming together at once to make meth more toxic today than it was 2 decades ago.